Think you know UTIs? Let's see if you can predict how a simple bladder infection becomes a kidney problem. A 32-year-old woman presents to the clinic with a 4-day history of dysuria, urinary frequency, and urgency. She also reports mild lower abdominal discomfort, but denies any fever, chills, nausea, or vomiting. Her past medical history is significant for recurrent UTIs, with 3 episodes in the last year. She is sexually active and uses spermicidal condoms as her primary form of contraception. On physical examination, she appears well and afebrile. Abdominal examination reveals mild suprapubic tenderness without rebound or guarding. There is no costovertebral angle tenderness noted. Laboratory studies show white blood cell count 9,500 per microliter, hemoglobin 13.8 grams per deciliter, platelets 240,000 per microliter. Urinalysis shows leukocyte esterase positive and nitrites positive. Here's your question. Which of the following mechanisms best explains how this patient's condition could progress from a lower urinary tract infection to kidney involvement? Your options are A. Hematogenous spread from bacteremia, or B. Ascending infection via ureters, or C. Direct invasion through bladder wall, or D. Lymphatic spread from pelvic nodes. Think about the most common pathway for UTI progression. Stay until the end for the complete breakdown. The answer is B. Ascending infection via ureters. Here's the key pathophysiology. The progression from cystitis to pyelonephritis typically occurs through an ascending route. This involves bacteria traveling from the bladder up the ureters to the kidneys. The patient's recurrent UTIs and use of spermicidal condoms, which can alter vaginal flora and increase UTI risk, make her susceptible to this progression. The presence of nitrites in urinalysis indicates gram-negative bacteria like E. coli, which are common culprits in ascending infections. Let's look at why the other options don't fit. Option A, hematogenous spread from bacteremia, is less common for UTIs. Hematogenous spread usually occurs in cases where another primary infection site seeds the kidneys with bacteria via the bloodstream. Option C, direct invasion through bladder wall. While local invasion can cause complications such as abscesses or fistulas, it does not typically lead to kidney involvement directly. And option D, lymphatic spread from pelvic nodes. This is not a recognized pathway for UTI progression to pyelonephritis. Lymphatic spread is more relevant in cancer metastasis. Try Boardmaster free today and master high-yield concepts faster. Thanks for watching and keep crushing those practice questions.